Hey everyone, and welcome to This Explainer. Today, we're about to unpack a truly fascinating medical mystery, pulling information directly from the clinical case notes of Dr. Hafiz M. Salim Danish, a specialist in internal medicine. What we're going to do today is actually learn how to look at the human body through the highly trained eyes of a diagnostician. You know, medicine isn't just about running lab tests and looking at scans. So much of it really comes down to the meticulous art of physical observation. So today we have a short case presentation that serves as an absolute masterclass in spotting distinct clinical clues. Let's get right into it. I want you to step into the shoes of an attending physician for a second. Picture this. You walk into the examination room, and sitting right there on the exam table is a patient who simply cannot seem to sit still. But, and this is key, it's not the normal, everyday fidgeting we all do when we're a bit nervous. You immediately notice a very specific, kind of mysterious set of physical signs. The patient's body is producing these involuntary, flowing, almost dancing movements. It's incredibly striking, it's highly unusual, and, well, as the doctor, it's your job to figure out exactly what is going wrong in their nervous system. So how do you take that visual puzzle and actually turn it into a concrete medical diagnosis? Okay, let's dive into this and look really closely at the exact clinical language Dr. Danish uses in his notes. He describes the patient's movements as brief, irregular, non-repetitive, non-stereotyped, semi-purposeful involuntary movements. Now, at first glance, that might just look like a giant list of medical adjectives, but in medicine, every single one of those words is a vital clue for ruling out other diseases. Because the movements are irregular and non-repetitive, we know we aren't looking at a tremor. Well, actually, a tremor has a steady, rhythmic shake, which is exactly what this isn't. The term semi-purposeful is absolutely fascinating, though. It means the movement might randomly look like the patient meant to do it, like they were suddenly swiping their hand to brush away a fly, but it was entirely involuntary, no intent behind it whatsoever. To further refine our observation, we have to look at how these movements actually travel. The source notes highlight that these movements start from one body part and flow right to another. Imagine a sudden jerk in the right shoulder that seamlessly cascades down into the left arm and then right into the leg. It's this specific, continuous flow across the entire body that gives these movements their distinct dancing quality. They aren't just isolated spasms locked to one muscle group. The physician has to carefully, meticulously observe the patient to catch this flowing, unpredictable physical choreography. Now, what's really interesting about this slide is how the environment and the patient's own intent completely change the symptoms. Dr. Danish notes that these dancing movements are present when the patient is completely at rest. Even just sitting quietly in a chair, the unpredictable flowing movements keep going, but crucially, they are accentuated by activity. If you ask this patient to simply reach out and grab a cup of water, that deliberate, voluntary action causes the involuntary dancing movements to flare up and become far more pronounced. This sharp contrast between rest and activity is a massive red flag that points our diagnostic compass in a very specific direction. All right, we've looked at the big picture. Now let's zoom in on our specific clinical signs, starting with hand posturing. I actually want you to mentally visualize this exact abnormal hand posture right now. You can even try to mimic it with your own hand if you want. According to the case notes, the patient exhibits an abnormal posturing where the wrists become flexed, curled downward, but at the exact same time, the fingers become rigidly hyperextended, pointing forcefully up and back. Spotting this highly unnatural mechanical tension, wrist down, fingers arched completely back, is a pivotal breakthrough for our investigation. And this brilliantly illustrates one of the most uniquely named physical signs in all of clinical medicine, the milkmaid's grip. The source material notes that when you ask the patient to simply make a hand grip, say you ask them to firmly squeeze your two fingers, they physically cannot maintain a steady pressure. Instead, the grip results in an alternate, erratic squeezing and relaxing, just over and over again. It literally perfectly mimics the rhythmic pulling motion a milkmaid uses when milking a cow. It's a fascinating clinical quirk that visually demonstrates the brain's complete failure to maintain a constant motor signal. From the specific grip of the hands, we're going to move to our next set of clinical signs, the challenge of sustained postures. This brings us to a formal, absolutely essential medical term, motor impersistence. Dr. Danish notes that the patient is fundamentally unable to maintain a sustained posture. Think about what that really means for a second. If you tell your arm to stay straight out in front of you, your brain is sending this continuous, sustained signal to your muscles saying, hey, hold the line. But in our patient, that continuous signal just breaks down. The motor command simply cannot persist. This entire concept of motor impersistence is the next crucial piece of our diagnostic puzzle. Let's move to and see how this builds into practical, everyday bedside tests a doctor can perform in literally seconds. Dr. Danish specifically documents the inability to maintain tongue protrusion and the inability to maintain eyelid closure. Basically, if the doctor asks the patient to stick their tongue out and just keep it there, the tongue will involuntarily dart right back into the mouth. It's actually often called a darting tongue or flycatcher tongue. Similarly, if asked to squeeze their eyes shut tightly, the eyelids will just unpredictably pop back open. These aren't signs of disobedience at all. They are the pure visual evidence of motor impersistence in action. At this point in the examination, the tension in the room really starts to lift as the clinical picture comes into sharp focus. We have gathered an incredible array of clues here. We've got the flowing, non-repetitive, dancing movements that get worse with activity. We have the flexed wrists and hyperextended fingers. We've felt the alternating squeeze of the milkmaid's grip. And we witnessed the darting tongue and fluttering eyes, proving motor impersistence. All of these seemingly disparate clues converge on one single definitive answer. And there it is, straight from the source notes. My diagnosis is chorea. Based on this exact, meticulous cluster of physical symptoms, Dr. Hafizem Salim Danish concludes the case. It's actually perfectly fitting, too, when you consider that the word chorea itself is derived from the Greek word choreia, which literally translates to dance. That historical naming convention just perfectly captures the flowing, involuntary physical choreography we've been investigating today. So the crucial point is how this all comes together to form a structured clinical framework. By breaking down the chaos of involuntary movements into specific symptom categories, general movements, hand posturing, and sustained postures, a really complex presentation suddenly becomes a highly organized diagnostic checklist. This brilliant breakdown illustrates exactly how doctors use pattern recognition. Spotting just one of these signs in isolation might leave you guessing, but grouping these specific clinical observations together, that is what empowers a physician to definitively and confidently spot chorea. We have successfully solved the mystery of what the diagnosis is, purely through the awesome power of clinical observation. But as we wrap up this explainer, I want to leave you with a provocative thought that pushes just past the physical exam. If the body is involuntarily dancing, if the grip is constantly fluctuating, and if the tongue just cannot hold still, what complex underlying mechanisms are misfiring deep inside the brain's motor command centers to create this reality? Understanding the outward signs of chorea is a massive first step for sure, but the fascinating journey to understand the neurology behind it, that is just beginning. Keep asking those big questions, keep observing the world around you, and thank you so much for joining me today.